All right, let's going to get started the last session for the afternoon, and I appreciate everybody's, the people who have stayed and the troopers that are staying with us to finish up phases of PAD 2022. Next section is going to be medical management of the vascular risk factors, and we're going to have Dr. Terry Melvin come and talk about things we can change. Terry.
Good afternoon. Let's see. Oh, sorry. Okay, so we're going to be, I'm going to go over some lifestyle modifications for tobacco use, hypertension, and hypercholesterolemia. Am I doing this right? No. Okay, there it is. So tobacco use is the #1 cause of preventable death and disease in the United States. The CDC put out a report in 2020, and just from cigarette smoking, the cost was $300 billion in medical care and lost productivity. So through the Public Health Initiative, when you look at data from 1999 and you compare it to 2018, and 2018 is just the most recent that's been out, there were 34.8% high schoolers that smoked in 1999, and in 2018 it had dropped to 8.8, and for adults it had gone from 24.1 to 13.7. But even with that, there is still a subpopulation of patients where there is an increased smoking, and that is people of color, low economic class, 22.6% of American Indians, people that are disabled, people with behavioral health, psychological disorders, and then sexual orientation, the LGBTQIA+ community. So what are the benefits of stop smoking or not smoking? Quitting smoking is a reduction in cardiovascular disease, COPD, secondhand smoke, and reduce the risk of cancer. It also reduces financial burdens on smokers in the healthcare system. It improves healthcare and increased life expectancy, and it reduces premature death. I think it's important as providers to, this is my mantra, if you quit and restart, you can always quit again. So if you quit and restart, you can always quit again, because smoking is going to harm every organ in the body. So how do we approach the client that's smoking? There's two questions. Do you want to stop smoking? And why are you smoking? And half the time they know whether they want to stop or not, but they don't know why they smoke. When you smoke, less than 10 seconds from the lungs to the brain, the tobacco, the nicotine travels. And what that does, the nicotine is going to attach to the neurons in the brain, and this is going to cause a release of dopamine. And when they get that dopamine hit, that is sensation of a reward. They feel good. It's going to decrease appetite. It's going to increase metabolism. The more a person smokes, it causes the brain to crave the cigarette more for another dopamine hit, and more receptors on the neurons are going to be formed. The body starts to think that it needs the nicotine to feel good. The longer the person goes without nicotine, the brain will return to normal with less cravings. I say that, and while I was kind of putting this together, I was talking to my daughter, who started smoking when she was in high school, and she was saying that even now, when she travels certain places, she'll reach over and try to grab the cigarettes. And what she tells herself is, not right now. Let me just wait 5 minutes. And she's not smoked in 6 years. I was also speaking with a close friend and just talking about smoking cigarettes. She says, I've not smoked in 15 years, and right now I could surely use a cigarette. So it is something that we need to be aware that the individual will need to be working on this their whole life. It's not as easy as just throw them in the garbage. For some people it is, and that goes back to why are they smoking. So in terms of treatment, helping with the withdrawal is a combination. It's going to be nicotine replacement therapy, but it's using long-acting, hello? What am I doing wrong? Hey? Is it? Try it now. There you go. It's going to require long-acting, such as the patch, and then shorter acting, something for breakthrough. Gum lozenge, nasal spray, plus some behavioral modification or coaching. And the person says, yes, I want to stop. The reason is, why do you want to stop? And part of each visit is to remind them what is their goals? Why do they want to stop? Was it so they wouldn't lose another limb? Was it so they could see their grandchildren? Was it so that they could just become healthier? There are some models for cessation. One is, oops, let me go back that way. It's called the 5 A's. You want to ask about the tobacco use. You want to advise in terms of side effects that you're seeing that the tobacco is causing. You want to be able to assess if the person is ready, assist the person, and then just arrange for follow-up. In the literature, it'll say, pick a day, and that's the day you're going to stop. You're just going to pick that day and you're going to stop. In my experience, that doesn't work. I see some people, they go well off, but then they start jonesing and they go right back on it. And I can tell you later kind of some of the things that we've used. Another is the 3 R's. How relevant is it for you to stop smoking? Again, what are the risks that the tobacco and how it is impacting not just you, but your family and your finances? What are the benefits from quitting? we helped out a homeless veteran. He's now deceased, but he smoked cigarette. He was a Vietnam vet, and every week I'd, go get groceries and drop it off to him. And I had to hide 2 packs of cigarettes because when he got down to 1 pack of cigarette, he would just start texting me and saying, "Are you coming today? Are you coming today? I don't have any more cigarettes." It was just something that was so overwhelming for him. But a carton of cigarettes back then, it was $60. And so if you kind of do the math, and that was at a cheapio place, and he was smoking some cheapy cigarettes because that's all he could afford, people can spend up to $400, $500 a month in cigarettes. And I think sometimes to break that down and give them that cost, it puts things into perspective. The roadblocks, what are some of the roadblocks? And then you just kind of repeat it. Stopping smoking, start the process on a day that maybe is busy. So I usually will say, when do you grab your first cigarette? If they grab their first cigarette before they even get out of the bed, and it's to the bathroom, before they go to the bathroom, I actually ask them to kind of write down what their feelings are when they grab that cigarette. Somebody's telling me I only got 5 minutes left, so I'm going to hurry. I think it's important when you are discussing this whole process of not of stopping or cessation of tobacco. We need to minimize the pressure. We shouldn't have any judgment, and we don't really want to guilt people into stopping. One technique I've used is, I'm not going to do it the first thing I do, smoke the first thing in the morning. I'm going to wait a minute. I'm going to wait until after I have my coffee. I'm going to wait until after this song goes off. And if they're smoking a whole pack a day, the goal is maybe to get them down to 15 a day. From 15 a day, I mean, it's a long process. It's like weaning them off until now they're only smoking 3 to 5 cigarettes a day. So that's just one way, but you always have to have that going back around and checking on them, and then making them realize why they have decided to do this. Okay, for hypertension, the interesting thing with me is, and I think Dr. Lassar said this last night, do you have hypertension? Do you even know if you have hypertension? Do you check your blood pressure? So you're young, you're healthy, you work out. How do you know you don't have it? How do you know you do have it? 35% of the people in Hamilton County have hypertension, but only half of them are being treated. So what are my risk factors? Did my parents, grandparents have hypertension? Do I check my blood pressure? So in my family, the women live to be old. Both of my grandmothers were over the age of 100. But then their sisters died in their mid to late 80s of what? A stroke. So as I'm going back and I'm replaying all of this in my head, I'm like, the stroke didn't start in their 80s. It started in their 50s. So I better start checking my blood pressure. And I have high blood pressure. So I'm on high blood pressure medicines. And what do? I follow up and I continue to check it. So I think you have to have that suspicion. There was, I'm not going to go over all these studies, but looking at, does it matter if a person's diagnosed with hypertension and they don't get treated? I think the way I've worded that, it's obvious that you really want to have a high level of suspicion. You want to encourage your patients to get blood pressure cuffs at home and record it write them down, and then bring them in on each of their visits. It is a silent, very subtle in terms of symptoms. Sometimes people have no symptoms at all. It's going to require a lifetime of medicines, their daily use, and it's a cost that's associated with that. Healthy lifestyle contributes to the control, but it takes practice. It takes practice to exercise. It takes practice for diet. And then to accurately diagnose it, we need to have several readings. So just the one-time reading in the office that's high, and I love my baby boomers to say, I have the white coat syndrome. And when you have them check it at home and they bring it back in, then they realize it's not quite the white coat syndrome. And it's nothing that they're doing. It may not be, they probably didn't choose their parents well, okay? Healthcare, it looks at the past and present design, and it reacts instead of being more proactive. And so I think as a provider, we need to be a little bit more proactive and have these people check their blood pressures, have them bring it in. If they're all normal, great, but 9 times out of 10, they won't be. So we know that hypertension increases stroke by 4 times and 3 times for coronary artery disease and renal failure. We know that what normal blood pressure is, 120/80. People that are at risk is anywhere between 139 and 189. And then considered hypertensive is 140/90. With weight loss, you can drop your systolic by 2 to 5 points. A healthy diet, by 3 points. Reducing sodium to less than 1,000 milligrams per day by 2 to 6 points. Increasing dietary potassium from 3,500 to 5,000 milligrams per day, reduce it by 2 to 5 points. Physical activity up to 8 points. Limiting alcohol 3 points, and then stopping tobacco 3. So we talked about some lifestyle modifications of checking the home blood pressure, exercise, diet. Ask them if they picked up their medicines. Ask them, have they been taking their medicines? Ask them, can they afford their medicines? Because 1 out of every 4 people that you prescribe blood pressure medicines to aren't even filling the medications. Ask them how many times they skip a dose of medicine. And 60%, the southern states are non-adherent, ranked 60%. I think that when we look at treatment of blood pressure control, it's not just the physician writing a script. It takes more of a team approach, such as everything is electronic, so if it's gone in electronically, the pharmacy gets it, and if the patient doesn't come to pick up the medicine, when that patient does come back to pick up something and start doing engagement about the medicines that were prescribed but not picked up. People need a wellness coach. They need some education on nutrition. The problem with this is that there's no reimbursement for this. In terms of wellness coach, tossing the tobacco, exercising, meditating, moving the body, de-stressing, maybe start taking some Tai Chi. So next we're going to flip over to cholesterol and Few changes in the diet will reduce the cholesterol and improve the cardiac health. So I think diet is everything, but I think I would be remiss not to mention the LDLs. So the American Diabetes Association, I think, met this past summer and have actually adopted an LDL of less than 55. And I think this morning it was also mentioned. So we were, last year, I think, was looking at an LDL of less than 70, and now we're really trying to push that to less than 55. So when we look at the approach or the guidelines, we want to look at the LDL level. We want to look at, do they or don't they have diabetes, and if they have diabetes, is there any secondary complications? And then you'll have the people that are just young and that are coming in and they say, what can I do so that I can decrease my chances of cardiovascular disease? And we can do what is called a atherosclerotic cerebral vascular disease estimate, looking at the 10-year risk of heavy CV event. And then we want to personalize that care moving forward. So how many of you in here have ever calculated your atherosclerotic cerebral vascular disease score? It's a percentage. Did I already pass that up? I think I did, didn't I? Yeah, there it is. If you haven't, I would encourage you to do it. So I think through this whole process of doing this, I was like 5.4. You know, I should be below 5. But, you know, I think if you don't do and test it, then you won't know it. Basically, it looks at the age, the sex, the race, blood pressure, what's your total cholesterol, your HDL, your LDL, if you have a history of smoking and or diabetes, are you on a statin, are you on hypertensive meds, are you taking an aspirin? Let's see. I did want to go back to this one. There we go. So when we talk about trans fats and saturated, unsaturated fats, easy breezy. A trans fat is going to be something that is used to extend the life of whatever you're putting in your mouth. That's a trans fat. So I ate healthy popcorn. Nah, there's no such thing. So these things that are listed in the trans fats are things that we want to start working to move away from. I tell my patients when they come in, you want to shop on the outside of the aisle. So you want to go to the vegetable section, across the back to the fish, chicken, beef, over to the eggs, cheese, and then back up around. And that going down the aisle is the devil. When we talk about unsaturated fats, they're listed: cold water fish, olive oil, avocados, herring, mackerel, tuna, flaxseed, sunflower seeds, so just naturally occurring foods. Now I can get to my last pearl. So lifestyle modifications, we want to look at a heart-healthy diet. We want to exercise, stop smoking, and I think it's important to get community connection. We're going to do better if we have someone next to us. Diet that's high in unsaturated fats and low in processed foods. Thank you.
Hello and good afternoon. My name is Monica Chamberlain and I am a nurse practitioner. I work for Vascular Institute. And Dr. Lassar very kindly asked me to talk to you today about risk factors for PAD and what we cannot change and how do we manage those risk factors. So far, we've been discussing risk factors for PAD that we can change. Those are cardiovascular disease and hypertension, smoking, high cholesterol, diabetes, exercise, and diet. So what are the factors that we can't change? I am so glad you asked. The risk factors that we cannot change include age, gender, family history, genetics, and ethnicity. For age, you can develop PAD at any age, but the risk increases as we age. This is due to the development of chronic health issues over time, such as hypertension, high cholesterol, and diabetes, but it's also due to the aging process. As we age, arteries and veins become more narrow and fragile, leading to microvessel disease. It is estimated that approximately 8 to 12 people in the U.S. and 200 million people worldwide are affected by PAD. 10% of individuals over age 60 have PAD. The prevalence of PAD increases with age. This slide is depicting the incidence of PAD as we age. Obviously, the risk increases significantly for both men and women with advancing age. For gender, both men and women develop PAD, but PAD affects men and women differently. Women are likely to have PAD without symptoms until severe disease develops. Women often don't seek medical treatment until the development of breast pain, which is a late symptom of advanced disease. This leads to increased complications and poorer outcomes. PAD appears to progress faster in women. Women produce more estrogen, and estrogen is an anti-inflammatory compound. When ovarian function changes during menopause due to the aging process, estrogen is diminished, and diseases that estrogen shielded become more prominent. Diseases such as cardiovascular disease, strokes, and PAD. This graph depicts women's rates of cardiovascular disease and PAD. The rates are not declining over time like they are with men. This is likely because there are more studies involving women now, not just men. In the past, studies were mostly done on males because of cost and convenience for not having to account for variables resulting from the estrous cycle. Women tend to live longer than men, and this accounts for some of the longer rates as well. Recently, the National Institute of Health put a policy into place called Sex as a Biological Variable to encourage scientists and investigators to use both sexes in their studies so that the information from clinical trials have a more meaningful and useful data. A recent study found that women who are diagnosed with PAD are more likely to suffer from depression. Ethnicity. PAD is significantly more prevalent in African Americans. They make up 11% of the U.S. population aged 45 and over. African Americans are more likely to have complications of PAD, such as walking with claudication and loss of limb. Hispanics and Latino people have slightly higher rates of PAD compared to non-Hispanic white people. The National Heart, Lung, and Blood Institute research found that rates of PAD are higher among Hispanic and Latino adults who have sedentary lifestyles, even if they do not have any other risk factors. American Indian women have higher risk of PAD than white or Asian American women. A study was done in Houston at the Veterans Affairs Medical Center to determine the prevalence of peripheral arterial disease in a racially diverse population. It was conducted in 4 veteran clinics in Houston. There were 403 patients, men and women, aged 50 and older. There were 136 white patients, 136 African American patients, and 131 Hispanic patients. Disease was diagnosed by an ABI of 0.9 or less. The prevalence of PAD was 22.8% among African Americans, 13.7% among Hispanics and 13.2% among white patients. African Americans have a significantly higher prevalence of PAD than Hispanics and whites combined. Family history. A family history of heart disease, high cholesterol, stroke, and blood vessel diseases such as vasculitis increases a patient's risk for developing PAD. A history of immediate family members with these diseases increases the risk, but having an extended family history with these diseases increases the risk even more. You can't pick the family that you are born into, but knowing this information can help a patient avoid risk factors for developing these diseases. In a 2014 observational study of over 4,500 patients with symptoms of vascular disease, the study concluded that patients with vascular symptoms whose fathers had PAD were at an increased risk of developing PAD themselves. PAD is the result of the complex interplay between environmental stimuli and genetic predisposing factors of the host. We're talking about genetics now. PAD is a complex disorder that is associated with multiple risk factors, such as aging, smoking, diabetes, high cholesterol, and hypertension. However, there are studies showing the role of inflammation in the development and progression of atherosclerosis, eventually leading to PAD. It is a highly prevalent condition with heritable components. Genetic susceptibility to PAD is likely contributed by sequence variants in multiple genes, and it is likely that there exists a set of variants that specifically alter susceptibility to PAD. These variants have not yet been discovered, and relatively little is known about genetic variants that may predispose an individual to PAD. Rapid advances in technology and bioinformatics drive current genetic biomarker research. In 2001, the Human Genome Project was completed, fully codifying the 3.1 billion nucleotides that make up our genetic code. Several young studies have indicated a heritable component to PAD, and this information is what is driving current studies. There are 3 types of genetic studies: the candidate, the linkage, and GWAS, which is genome-wide association studies. The candidate study is an association between a specific genetic variant and a disease of interest. It is an individual case-based approach. The linked analysis study is when the genome is scanned for highly variable pre-specified DNA markers. It is a family-based approach. Some regions present deceased family members for testing, which helps in mapping, which is known as positional cloning. GWAS researchers can now scan the full genomes of large cohorts of patients to identify variants that are overexpressed in a given disease and compare with unaffected cohorts. Candidate gene approach and linkage studies help in designing studies with uncharacterized genetic determinants. GWA studies help in collecting the accurate genotype information in samples of sufficient size. The application of these technologies to PAD needs encouragement. In the near future, it is likely that genetic variants that are specific to PAD will be uncovered. Further studies may yield useful genetic biomarkers, helpful in diagnostics for PAD, and provide insights into the pathophysiology of the disease. This information will help in designing new and efficient therapies for the treatment of PAD. A genetic marker for PAD could identify individuals at increased risk for PAD who may benefit from targeted therapies to delay or prevent the development of lower extremity atherosclerosis. A greater understanding of how genetic variation influences susceptibility to PAD may inform the development of new therapies. In conclusion, PAD prevalence in the U.S. is on track to triple in the next 30 years unless we work to prevent it. That's why we are passionate about our patients. That's why we're here at this conference today, to learn about PAD, risk factors, prevention, and treatment modalities. Early screening for PAD is crucial for detection and treatment of PAD. Screening for women is important due to limited symptoms until late stages with increased complication rates and poorer outcomes. More attention to diverse ethnic groups for early detection of PAD is needed. This is why we appeal to our primary care physicians to refer their patients to vascular specialists early on. Those with family risk factors and other PAD risk factors are encouraged to undergo ultrasound and ABI testing. Genetic studies for PAD is on the frontier. An advancement in new treatment modalities for early detection and prevention is on the horizon. Thank you for your time and attention.
Hello. I guess going closer to the end is helpful. Maybe you'll all be awake. My name is Jamie Moses. I'm a nurse practitioner. I work with Dr. David Huffman. We deal a lot with diabetes. I also have diabetes myself, so hopefully keeping my blood sugars down will keep me from having to see Dr. Lassar or anybody else for that matter. So I have nothing to disclose financially. Yes. At least somebody laughed. I was like, someone's got to laugh at my slides. So the recommended guidelines, if the ADA comes back and says our A1C should be less than 7, has anyone ever thought about what that would be blood sugar-wise? Probably not. You're thinking 7's great, right? It's not. No, you're right. If you thought about that, an average blood sugar would be about 150. Average blood sugar is 70 to 100. So when patients come into my office, they say, what should my A1C be? I hate to give them an answer because the answer really should be blood sugar around 100. If you have a blood sugar around 100, your A1C will be low enough to hopefully prevent complications, PAD, PVD. So when a patient comes in and I'm starting to talk to them, I say, okay, what do you want out of this visit? I want to know what they want, not what I want for them. Because what I want for them is improvement in life, longevity, fewer complications. They may say, well, I want my A1C to be down. But really it's sometimes, well, my wife wanted me to come, my kids think I need to do better. Okay, well, I'll use that as a starting point to help them understand about diabetes and allowing me to help them improve things long term. So diabetes management, knowing your numbers. It was years ago, the first machine came out, you could actually check a blood sugar. You didn't have to urinate in a test tube and put a tablet in there to see what color it turned, which would give you an estimate of what your blood sugar might be. Now we have glucose monitors. That's great. You could check 4 times a day, but the average person will not check 4 times a day. Now we have Dexcom, Libre, Eversense. These monitors have revolutionized how we can evaluate how our patients are doing. Instead of just giving points in time, I can actually see the rise of their blood sugar, how long they stay elevated after a meal, when they come down. If they say, I'm having episodes of hypoglycemia, I can see that. If they're saying I'm having hypoglycemia and I don't see it, I can pull my computer screen around and say, show me where. There's something that I'm not picking up on, maybe you can help me. But just because we know numbers doesn't always help us understand how to take care of a patient. There are many types of medications you can give for diabetes. You can do orals, you can do a GLP-1, GIP combo. You can do insulin, and you can do insulin and GLP-1 combos. Now, the biggest ones that are out on the market right now, probably, which Dr. Bailey alluded to this morning, are probably the GLP-1, GIP combos, and the SGLT2 medications. All of those help improve diabetes, they improve renal function, and they also reduce the risk of cardiovascular events. But we also have to make sure that we educate our patients. We communicate with them, not just saying, here's a pill, here's a medicine, take it, it's going to improve the diabetes. We don't tell them why they're taking it and how they should take it. It's not going to help them. We also have insulin pump therapy. That has greatly improved. We can have someone be in California and I can see their insulin pump data. Remote monitoring. It has really helped me. I actually did a telehealth visit with a girl in Dubai. So I think that's the farthest I've done a visit with somebody. But I was able to see her data. She didn't have to be in the office. And these new systems work with the sensors, the glucose monitoring systems, to help regulate blood sugars. They will increase your insulin needs or decrease them based on the algorithm that is programmed into the pump, which is very helpful. So when we look at diabetes management, medication's great, insulin pumps are great, having the Dexcom sensors are wonderful, the Libre sensors, the Eversense, but if we don't look at it as a whole picture, we're never going to get them where they need to be. So we start with nutrition. Dr. Huffman in our office, we like for the patient to see our dietitian every year. Now, Dr. Melvin alluded to, a lot of times these things are reimbursed, but if we don't do it, who's going to do it? So we look at their diet. And the biggest thing when I was diagnosed is you have to follow the diabetes diet. Well, what is that? Does it mean you can't have anything ever in your life? If I told that to one of my patients, they'd look at me and walk out the door. They wouldn't come back to see me. So we look at how can we get them to eat healthier, change their behaviors, and if we can do that, we'll improve their numbers and improve their diabetes. So you always have to look at their socio and economic status. They may not be able to afford the healthy foods. How can we encourage them to look outside the box and in terms of making things better for themselves? Also, we look at carbohydrate counting. People will come in and say, well, I take 20 units 3 times a day. So I'll go, so you'll take 20 units for an apple? Really? Maybe we should look at that. Maybe we need to change our way of thinking about food and how our blood sugars are affected by the foods. And then, of course, this aids in us dosing their insulin properly. Because if you have a low blood sugar hypoglycemic event, that is one of the biggest fears you will find in your patients with diabetes. They are so afraid of having a hypoglycemic event, they won't take their medicines. They definitely won't take insulin because that's the no-no of the bunch. So if we can help them understand the big picture of that, you'll get better response. And so who's going to educate? Well, is it just a nutritionist? No, it's not just a nutritionist. We also have to rely on our office staff. We have a very interesting group at our office. We have a lot of people who have diabetes. So it makes our office one where people want to come to because we understand it's not just telling people, this is what you need to do. I don't want to tell people what they need to do. I'll give them advice and give them my medical opinion. But if they understand we deal with that too, they're more likely to listen to us. And we also have a diabetes educator who deals with pump trains and things of that nature. So she is also involved. We define what diabetes is because some people don't know what diabetes is. They know their blood sugar's high, but that's about it. And it gives the patients the how and the why of what's going on. And also we look at how to take medicines. Recently, I increased the gentleman's Ozempic to 1 milligram. He started at 0.5, I bumped him up to 1 milligram. I was out of the office for a week on vacation. I come back, there is a 2-page letter sitting on my desk. I'm thinking, oh no, what's going on? So I read it. Dear Jamie, my blood sugars are elevated. I have gained 10 pounds since you have changed my medicine. I'm thinking, surely something's going on. So I call him and I say, hey, what's going on? I'm taking that drug like you said, but something's not right. I'm like, well, you're coming in like 5 days. Bring your pen with you. And I said, I want to see how you're dialing it up. Well, he sits there, pulls out the pen, and to dial to a milligram, I think it's 72 clicks. Gentleman pulls it out, 1 click. I go, so you've just been doing 1 single click. Yes, and it's not working. Well, here's where I want you to go. So sometimes maybe my communication, when I thought it was okay, it wasn't okay with him. So I learned from an endocrinologist up in Nashville, Dr. Snow. He had a patient that was taking 50 units of insulin 3 times a day. Blood sugars were staying up, poor control. He had the lady bring in the shot or the pen needle. He said, I want to see how you inject it. The lady said, okay. She's 81, I think. Leaves the little blue cap on, turns it to 50. He's like, no wonder. I'm glad she left it on, because if she had actually taken 50 units, she would have been in trouble. So we need to make sure our patients understand what they're doing and how to take the medications, when to take the medications. It is our job to communicate that with them, but then they need to communicate back with us what they learned. So, barriers. We all have barriers. I know that each and every one of us deals with those. Financially is a huge one. Not even just my Medicare population, but my private insurance. They have such high deductibles. You throw on a GLP-1, insulin, an oral, not to discount the other medicines they're on. I mean, that's really expensive. Inflation is going on, cost of everything is going up, and you're going to add another drug. So you might want to just ask, okay, hey, why are the blood sugars running higher? Ask them, are you taking your medicines every day? If they're not, ask them if it's financial. You're not trying to find out how much money they make. That is not my job. I don't want to know that. But I do want to know if it's a financial situation. They do have patient assistance programs out there. We all get samples. If there's a sample in your office and you've got a patient like that, give it to them. If they need to make it to the end of the year and you can do that, absolutely help them out. Emotional. I had a lady come in the other day. Her A1C had been in the low 6s, and when I saw her in the office, it had gone up to 7.4. I said, what's going on? We were doing, an A1C of 6, and now we're 7. Well, it turns out her 18-year-old left on his birthday and never came home. He moved in with his 16-year-old girlfriend with her family. And I said, enough said. This is a number. Numbers can go up, but they can come down. Emotional stressors will cause the blood sugars to go up. And of course that goes into family stressors, because that was definitely a family stressor. And then learning disabilities. I have people that may be dyslexic, maybe they are mentally not able to understand what I'm saying. So talking to them and working through this will definitely help you achieve the number you want. So support systems, here's a few that I know about. Us as providers, we can take the 5 extra minutes in the room to help explain things. That might be all that they need. Family. Family can be a support system, and they can be, unfortunately, a hindrance. I'll have family members come in and say, well, John should not be eating that, or John doesn't check his blood sugar. That's not really helpful to John. John needs someone to say, you're doing a great job. Maybe if, I gave him an apple instead of a Twix at bedtime, he would do better. So a lot of times families have a negative connotation, which does reflect on our patients and doesn't make them want to do so well. But families can be supportive. I've had many families come in that are like, hey, Jane, she's checking her blood sugars. I'm helping give the insulin now. I'm, cooking them a meal so they have something nice to eat. It's healthy, and they're actually gaining weight and feeling better. There is online support. I put that on there, but there's Dr. Google out there, and I don't like Dr. Google. Dr. Google gives out way too much information that is typically not accurate. But there are some online support that is helpful. So you just have to pick and choose what you're going to listen to. And then the community. There's lots of things that the community has to offer. We just don't show our patients or tell our patients what is out there. So communication. Every patient is different. If I thought about coming to the room, talking to my patients the same way day in and day out, my patients would leave feeling defeated. So I'm going to curtail that to what they need. And I'm going to collaborate with them. Hey, if things aren't working, you call me. If in a week those blood sugars are not down to, 100 or close to 100, call me. Don't wait 3 months till you come back in, because I can help you. If I can help you now, we can fix the problem. And listening to their needs. A lot of times we want to just tell people instead of listening. I've learned that throughout the years. Sometimes I do better, sometimes I don't, but I do try to listen as much as possible. And I try to keep it simple. I do not throw everything at them, especially that first visit. They're not going to remember a thing I say. But sometimes I need to make it simple, and then I build on top of what I'm telling them. And then I need to give them more credit. I always try to encourage my patients and say, you've really done well. You have gone from an A1C of 8 to an A1C of 6.5. That's amazing. Because most patients, when they come in the office, they don't want to come in. They always feel like I'm going to be mad at them. I've never yelled at anyone. And that's what I tell them. I'm like, why would I be mad at you? Because if I'm mad at you, I've done nothing more than discourage you. And having diabetes, seeing what other doctors have done to me in the past, why would I want to do the same thing to you? So if we have a supportive system, a supportive staff, giving patients encouragement, they'll do better overall. Communication to avoid, and this is how we'll close. Let's try to avoid good and bad. Patients come in the office and say, well, my blood sugars have been bad. I'm like, are you a bad person? No. Well, bad people, aren't they in jail? Or they should be. Well, I'm not bad. Well, why are your blood sugars bad? Give me a number. Tell me what they are. Well, if a blood sugar's high, there's a reason. Maybe I haven't given you the right medicine. Maybe you didn't take the medicine because of X, Y, and Z. Otherwise, me saying bad is just making you feel worse, making you not want to come into the doctor. And if you don't come in, I can't help you. If I can't help you and keep your numbers down, you'll end up with complications in the future. Also, phrases like, you should have done. Well, you should have done. Well, that sounds like your mother. I'm not your mother. You've got one, right? So, encouraging them to improve their situation. That's the biggest thing. And then never express your assumptions. Well, why didn't you check your blood sugars? Well, maybe they did, and maybe they have a second monitor at home they didn't bring. Don't just assume things. So, if you have any questions, you are more than welcome to ask me. If not, I'm done. So.